I think the federal antitrust agencies are very responsible in the cases that they bring. Ultimately, many transactions, even transactions that they investigate, get cleared. So I don't think anybody should be expecting a swarm of FBI agents every time they propose a transaction. On the other hand, I think the antitrust authorities have decided to set a tone and are skeptical when there are hospital-to-hospital mergers, particularly in smaller communities, or increasingly when there are hospital acquisitions of significant physician practices. I personally disagree with the federal antitrust enforcement agencies in some of these cases, but I do think it is a real risk. Well, I think federal intervention comes from two directions. Usually there's somebody who is unhappy about a proposed transaction and they make that unhappiness known. Sometimes that would be a legitimate concern in economic terms, in that it would come from a customer, maybe from an employer in the community, perhaps from an active health insurer or payer. Other times the complaint comes from a competitor, and economists and the antitrust authorities view that with skepticism, but they're still likely to poke around a bit when they get that information. So once an investigation's launched, then the question becomes whether the antitrust enforcers would be able to prove their case if they did have to take it in court. And then you're generally getting into the characteristics of the markets. And here's where I depart from a lot of the analysis that the agencies use. They tend to do most of their merger and acquisition enforcement in small communities because they can define a geography that seems pretty constrained, and then that they can demonstrate that the merging parties have a pretty large share of the market they've defined and would have an even larger share after a transaction went through. So situations where a community has 4 hospitals that might go to 3, or 3 hospitals that might go to 2, become of paramount concern. So those are the common features. Then after the investigation proceeds, they might be concerned that there's documentation where people have talked about their desire to raise rates or their desire to increase their bargaining leverage. I think most people either don't really have those motivations or know enough not to put them in writing. But those types of common themes obviously will enhance the case. My departure from the antitrust authorities on a lot of these cases is I don't think that these communities are really the source of the greatest problems of inefficiency and anti-competitive behavior in healthcare, and I don't think that communities that have more hospitals and more people where the authorities would never bring a case are actually models of efficiency. And so I think this is often a lot more waste of resources than it is true competitive benefit. I think the agencies will continue to do what they're doing unless and until the courts tell them to stop. I don't think the courts will tell them to stop, because I think everybody learned some lessons in the 1990s about some acquisitions that did result in higher prices and harm to consumers. So I think if this is going to ease up from the agency's perspective, it's going to ease up because they decide that other priorities are more important. And there are certainly areas that they're working in that have other priorities. They are scrutinizing the anti-competitive potential of state professional boards, as in North Carolina in the dental case that the Supreme Court is hearing in October of 2014. And then there are other areas where they've been scrutinizing contractual relationships involving large insurers and large providers. And it may turn out that those areas become more active and more important to the agencies. But pending that, I do think that the agencies are going to continue to scrutinize transactions, particularly in smaller communities.